bigger and bigger. Thanks everybody for coming out. I have the privilege today of talking about something that I'm not sure I feel very comfortable about talking about because I think we're going to need a lot more information to kind of tell you more, and that's a little bit of what happens when you're talking about things that are kind of hot off the press, and we're still trying to kind of understand and digest them a little bit. So that's my biggest disclosure that I will have for today. There were a lot of things presented at the meeting, and I would say there were two things I was really excited to kind of hear about at this meeting. Primarily hearing about the latest, the new data that was presented on tolebrutinib, which is a BTK inhibitor, and I'll talk a little bit about that data. I think the data asked us more questions that we're more interested to hear about more and excited us more than maybe in the past. But as far as kind of answering some of those questions, we're starting to get a little bit of data on that. And then the other piece that I'll talk about is completely switching gears completely to talking about the new diagnostic criteria for MS. This got changed big time. I think it's a lot of stuff we were doing to some extent. But in the past, usually you would get one change per new update. And I think there's like 10 new things in this new update. So I'm going to try and make sense out of it. And the disclaimer there is this was presented at a meeting in which the presenter stopped twice to say, you will not understand this. It is too complicated. And the paper has not been written, as far as I know, as a draft or even submitted, knowing some of the people that were involved in that diagnostic criteria. So with all those caveats, I'll introduce some of this data. So with some of this conflict of interest, part of this is we were part of the tolebrutinib trials, and I've done some advisory boards with Sanofi related to this. So let's talk a little bit about tolebrutinib. This has been a field that's been very interesting, and not just us, but from a pharmaceutical company perspective as well. I think I've counted at least 8 different BTK inhibitors that have been studied at some point or another for MS. Some have kind of fallen off, and some have continued on. Of the ones that have kind of made it to phase 3 trials, kind of the big ones, last year we heard about something called evobrutinib, which did not really pan out in relapsing MS. The second one is this one, it's tolebrutinib. And the ones that we will start to hear about more next year is something called fenebrutinib. And the fourth one, remibrutinib, is short on its heels. Biogen has a compound that's also being looked at. So again, there's several of these with a couple of them that have already kind of fallen off for some reason. The interest for BTK inhibitors is because they make it's a small molecule, so it gets away from a little bit of what we've been thinking about usually a lot around here, especially of using big antibodies. As a molecule, as a chemical, right? An antibody is a really big molecule, and it has a really hard time making it into the brain. So this has that ability to kind of cross over. And then the other piece is that BTK is an enzyme that is involved with several aspects of the immune system. BTK being Bruton tyrosine kinase and not associated with the serial murder. But in B cells, BTKs are important in signaling through the B cell receptor. This looks like an antibody. It's drawn here as an antibody, but it signals through here, and tolebrutinib inhibits this signal molecule, and this, if not inhibited, would then lead to B cell activation, making more antibodies, making those cytokines, those chemicals that tend to turn on the immune system. B cells are involved in activating other types of immune system cells called T cells and macrophages and all kinds of other cells. And so by inhibiting that, it kind of prevents some of that activation. Additionally, in another type of cell, the microglia, these are cells that are a little bit more involved in what we call the innate immune system. So when you get exposed to something new and you've never seen that before, your immune system can react to it. It has to learn what that is. And that shifting of kind of if we don't know what it is to something where you start to learn what it is, this molecule does both of that. So on the microglia, we tend to think about it being more of hey, how do I learn how to fight something? And I can fight it without knowing what that is. But it's not me, so it shouldn't be here, and I should get rid of it. B cells are more of the adaptive part of the immune system, so part of the immune system that's involved in learning how to fight new things. Microglia, then, it doesn't work through B cell receptors, but in these types of cells, there's an Fc gamma receptor, and there's a series of them. These recognize antibodies that have bound stuff that is not recognized. And so when it binds this Fc receptor, then it signals through BTK to lead to this activation of microglia. So in other words, just to simplify this, it works by limiting the immune system from attacking itself. And that's the part that we're excited about by being able to do that in a couple different ways. So let's talk about the different, there were 2 trials that were presented. This was probably the largest program of trials ever done to try and get a drug approved. It involved 2 trials for relapsing MS, which I'll talk about, a trial for non-active secondary progressive, which I will talk about, and a trial for primary progressive MS, which is still ongoing, and we don't have data for that one yet. But these kind of finished off around the same time. So the 2 trials for relapse and remitting MS are called Gemini 1 and 2. They look very standard as far as what relapsing trials look like. You could get randomized to either getting the study drug, tolebrutinib, or a placebo, or teriflunomide and the placebo. So in other words, you're getting tolebrutinib or teriflunomide. This included over 1,800 patients, so again, a big study. And baseline characteristics for this were fairly balanced out as far as what the patients looked like that got one drug versus the other drug. Sometimes even by randomization, that doesn't quite happen, but in this case, it worked out pretty well. So let's talk about the primary endpoint, which is relapses. All right, so for relapses, so we look at Gemini 1, Gemini 2, and we can look at them pooled. You can see basically it looks like a flat line. It looks very similar. Teriflunomide here, tolebrutinib in a purple color. There was no difference. So as far as clinical disease activity, not much difference between these 2 drugs. So it's not to say that the drug didn't work, but it matched one of the drugs that is one of our weaker drugs, and that's the reason they chose that drug. They didn't go up against a big gun drug, and so they did not see much difference. One of the interesting pieces about this is that the numbers themselves are not that high. So when you're looking at even the teriflunomide arm, this rate of relapses of 0.12 and 0.11 is extremely low. When you look at some of the trials that were done even 5 years ago with big gun drugs, the number of attacks were even higher than this. One interpretation for that would be is that teriflunomide learned how to attack MS better over the years and started to reduce number of attacks better. I think one of the things we can probably assume is that's not the case. And what I would assume to say is that we're probably seeing that the patients going into these trials are not as active as they used to be. If I have a lot of drugs to treat MS, and the people that I want to treat have options for treatment, I might not put them into a trial where they could end up on one of the drugs I'm not very excited about. So if you pick people that don't have a lot of disease activity, your number of attacks is going to be much lower as you study these patients. So that as a background might help explain a little bit of our data with this. I think this is where it gets interesting. So there's not much of a difference on clinical relapses, but when we start to look at progression, So this is CDW, or confirmed disability worsening. In other words, you're going along and all of a sudden you get worse on our disability scales, and that gets confirmed at 6 months. That is a confirmed time point for this study, okay? So it's not that you get worse and then get better, but how many events of that being confirmed 6 months later are occurring? And we see a reduction of 29%. That was statistically significant. Because of our rules for studies, if you don't meet the primary endpoint, you're not supposed to look at these, but we still do because we can still learn about these drugs. And this, I think, helps support the next trial that I would talk about. If we look at confirmation at 3 months, we see that it's actually the 3-month data look very similar. This is a little bit of a different time point. So these are patients that actually got better. So confirmed disability improvement, or CDI. This is kind of a newer measure that we're starting to see. With newer drugs, we saw that some number of patients got better. So here in the order of 12 to 14% of patients in these trials got better. We know that after relapses, most patients, we expect half of them to improve or to remit, and that's why it's called relapse and remitting disease. The difference was not statistically significant, but again, a little bit of a trend to saying that tolebrutinib looked a little bit better than Obagi or teriflunomide. When we look at number of lesions, this is where the confusion really started to kind of pop up. So when we look at active lesions or contrast-enhancing lesions, you will see that there were almost twice as many lesions on tolebrutinib as there were patients on the comparator drug on teriflunomide. So how do you have more MRI disease activity but can still have an improvement in your disability? This goes completely opposite of what we tend to associate with MS, and as far as we understand it, this is what's causing a lot of confusion around trying to interpret these trials. As we get more data, we might be able to explain some of these things out, but this is where we're stuck a little bit at now. So the idea might be is that old lesions start to become active, and so they're not maybe new lesions, but they're getting reactivated because it's not a great inflammation drug. That could be a possibility. We might be able to see this as we start to look at different time points, if this is happening early versus happening later in the study, and those kinds of things. When we look at new and enlarging lesions on T2, and notice there's a lot more of these than there are enhancing or active lesions, there's a trend to being more lesions with tolebrutinib. The difference is small. And the numbers, though, are pretty big still. So we're seeing 5 new lesions on these scans. I suspect that this has to do a little bit with how and what they're counting. And the question that we have is how many of these are really new lesions versus how much of these are enlarging lesions? And they use a little bit of a computer algorithm. So this may not necessarily be what we reflect on a little bit. But those are the questions that we're kind of getting asked and trying to understand. If you have more MRI disease activity, then you would expect to see more brain volume loss. This is the brain volume changes that we see in these patients. So in Gemini 2, there was absolutely no difference. But in one trial, and this is a reason why the FDA requires to have 2 trials a lot of times because they don't always agree. And so you want to kind of see some consistency for this, is that the tolebrutinib patients had less brain volume loss than the other patients did. So more lesions leads to less brain volume loss. Again, not something we can understand, but this is why there's confusion at this point in trying to interpret these studies. Before we sign up to do this drug, I'll bring up some safety issues. So this drug got put on an FDA hold for liver issues. We can see that teriflunomide had liver issues, usually on the small scale, not a lot of very small changes in the area that we don't normally tend to worry about too much. But as you start to kind of see big enzyme changes in patients that we call DILI or spacing out on what that stood for. Drug-induced liver injury. There were 4 cases that met that criteria, that basically led to that drug being put on hold. And we did see that teriflunomide so had some hair thinning and some of the other things that we tend to associate with these medicines. But we need to understand this a little bit better. There was a program put in place for when patients can start to cross over to monitor liver enzymes more frequently. So we'll have to see how well that works and things like that. All right, let's turn our attention to the progressive trial. We look at progression a little bit differently. So again, this is the design for the trial. It's still a fairly big study, fairly well balanced between the arms that went on, in this case, to placebo. The reduction that we saw in that confirmed disability progression was 31%. To put it in perspective, the confirmed disability progression that we saw with the ocrelizumab trials is 24%. Again, these are not necessarily the same patients, so we cannot compare that number and say, oh, this must be better. But at least it got our attention to say, hey, these numbers are probably going along with what we see, and they're matching up the numbers that we saw from the relapsing trial to make us at least interested to kind of say this drug might be legit for progression. How good is it? All these other things, we're going to need to understand who were the people that got better. Were they the ones that had no MRI activity? On Ocrevus, they lost that efficacy. And so, again, more to come as we start to split out some of these groups and understand a little bit who more benefited from this. We can look at confirmed disability improvement. And statistically, there was more people doing better on this drug. Please note the small number of patients, okay? So when we say that we're not expecting improvement, but, you know, some people do. Could this be by chance? I mean, you're having progressive patients who got better on placebo at a rate of 5%. So again, there's some noise in some of our measures, right, that we need to understand for some of these things. When we look at MRI activity, there were more lesions popping up in these non-active patients. So you will have to figure out how non-active patients, if they're having MRI activity. But there was more MRI disease activity in the placebo than there was in the patients on tolebrutinib. So again, suggesting that the MRI activity is maybe better than nothing, it's just maybe not as good as teriflunomide is. As we look at brain volume loss, really not much of a separation in these patients. So this is kind of our big MRI metric, and not seeing a difference makes us a little bit nervous about this. And then on the liver enzymes, we see this same pattern. Again, teriflunomide has some liver stuff, so a little bit of separation throughout this. I will point out that there was one death associated with this liver enzymes. The patient required a liver transplant and did not do well from his liver transplant and ended up passing. So again, we were going to have to not necessarily, I'm not sure this is a drug for everybody. We're going to have to be very careful about sort of how we look at these drugs, but I think it presents a little bit of comfort for looking at this, okay? All right, I'm going to talk a little bit now, switching gears to the new criteria for MS. So Xavi Montalban from Barcelona was able to present this data. He led the group that met in December of 23 to revise these criteria. They came up with some general principles. The general principles still hold. You must rule out everything else, like pretty much everything else in the autoimmune world. But there's a couple of things that stand out compared to what we had in the past. It almost kind of requires that you start needing an abnormal MRI showing lesions typical of MS in order to be diagnosed with MS. Again, that's something we have done at our center for a long time, but it's one of those things that as we look at things, to kind of keep in mind that these things are just getting a little bit more formalized. As I said, usually most of these criteria have added one thing. This added all of this. Sometimes there's just refinements of like, we can measure this in a couple different ways. And again, until we actually see what the criteria finalized is, we're going to have to interpret this a little bit with caution. but I'm going to go through this to some extent, okay? The biggest change probably that did happen was something that should have happened probably 50 years ago, and that is something that the optic nerve is now part of MS. So seeing everybody here, right, I guarantee you that multiple of you started with an optic neuritis to set up your journey into MS. This is 20 to 25% of MS patients start with an optic neuritis, so it's time for it to be part of MS. When we talk about the other lesions, here's the optic lesion and optic nerve. This is the nerve coming out at you. We talk about periventricular lesions, juxtacortical lesions, brainstem lesions, and spinal cord. So this becomes the fifth in addition to the other four areas that we have traditionally considered MS. Because it's a new area, then you have to kind of include some caveats associated with it. So you must rule out other things that could cause an optic neuritis, which is many different things. On MRI, for example, you want to see lesions not necessarily involve the optic chiasm, because that tends to be associated with NMO disease, or having a perineuritis or inflammation just around the outside of the optic nerve, which tends to be much more common with MOG-associated disease or MOGAD. To measure optic nerve, it doesn't necessarily just mean MRI, but you can also identify these lesions with either a visual evoked potential, which we don't tend to do much anymore, or an OCT or optical coherence tomography, which are some pictures of the back of the eye where they use infrared light, almost like an ultrasound. We also got rid of one of our core principles in the sense that in the past we said you had to meet dissemination in space. So that's the 5 areas now that we have, but it also got rid of dissemination in time. This was to try and establish MS as a chronic disease. So it's not that we're not saying MS is not a chronic disease, it was just that if it looked like MS from the first get-go, most patients go on to become a chronic disease, so we should just treat it as a chronic disease. And it allows us to kind of diagnose things earlier and earlier. The prior changes that we had included things like we can look at MRI changes to say that meets dissemination in time. In the last version, they added spinal fluid markers, which allowed us to say that's kind of the same time because it takes time to develop that inflammation for us to develop that. With those changes, we can now measure that dissemination in time through a number of other things, which is kind of a lot of stuff that was added in to measure that. So we already had oligoclonal bands, but now we can do kappa-free light chains, for example. So when you make antibodies, you make an excess of this arm of the antibody, which can float around, and these are fairly easy to measure. So you measure these kappa-free light chains, and if they're high, that tends to be an indication that you're making those in spinal fluid. And so these elevated number in those go up really well with oligoclonal bands. So if you can measure that, it's less of an issue in the US because we have good access to labs, but in the rest of the world, this becomes really important. The other thing is if you have a lot of spaces affected, so in this case 4 out of the 5, you're done. You don't need to get spinal fluid. You don't need to do anything to measure it. If you only have one area done, then it starts to bring in some extra measures that we can look at. So something is called central vein sign. If you got 6 central vein signs, here's a lesion with a central vein. We've always known that inflammation, and we really have known this, it was just really hard to look at it, but the MRI techniques have gotten better where we can start to do this. We can do it on a research basis. This is one of the caveats about it. We don't do it clinically quite yet. But if you can see that vessel in the middle of a lesion, that tends to be fairly specific for MS. It's not 100%. There's weird conditions that can do this. Mitochondrial disease, Susac syndrome can be associated with a central vein. The other one that got added in is pearls. These are even harder to measure yet for us. And basically, there's a lesion here in this yellow arrow, and you can see the rim around it that's dark. And that has to do with iron being accumulated or blood products being accumulated in macrophages at the rim of an MS lesion. This appears to be more specific to MS And if you see one, then you're good. The problem is it's not very sensitive. Only maybe 10 to 20% of patients have these kind of lesions associated with them. But if you have this in one lesion, then you're good, and you can say, hey, this looks like MS. We can start taking it back to just radiologically isolated syndrome. So a patient who has not had symptoms from MS, we can start to diagnose as MS if by MRI they have at least 2 areas and they have new lesions come up, if they have oligoclonal bands, or they have these central veins. So again, you're seeing a lot of caveats. I wouldn't memorize this. This is the part that got really complicated. It's just adding more ways to diagnose MS earlier and earlier. It added some subpopulations. So in pediatrics, for example, it added the fact that if you're 12 or under, you really should be testing for MOG. If you're between 12 and 18, you probably should be doing MOG. So it's just trying to add importance around MOG in pediatric populations. If you're older or have vascular risk factors, again, what those are, what they look like, we haven't defined that yet as far as what we know. I doubt they will. Then you want to have a little bit of a higher bar to diagnose MS. It's just a little bit more unusual. So ways that you can do that is requiring that one of the lesions be in the spinal cord, that you have the positive spinal fluid, or you have some of those central veins. For primary progressive, it allowed you not to have any brain lesions, but if you have multiple spinal cord lesions, which is a caveat that I've seen maybe once or twice, so it does happen, now we can call that to be MS. And it defines progression as happening over 12 months. So again, it's just adding more nuance to the criteria. It's not really changing how we think about it. These are diagrams, I'm not going to go through them, but just to highlight, everything in red are new things that got added. So this whole branch got added, half of this box got added in. And when we're looking at some of these areas with RIS, a whole other branch that got added in. So we can diagnose things a little bit earlier. I think some of these are adding some specificity so we can clean up some of the things that we were calling MS that weren't MS, and we can diagnose things earlier. So tolebrutinib reduced progression, maybe not relapses. Who benefits and how do we monitor the liver stuff, I think is up in the air a little bit. And then the new criteria, we still need to confirm what the final look of it is, but at least at first pass, it's adding some more nuance. It's getting a little bit more complicated, but I think it's stuff that we would all agree becomes important to kind of try and understand this very complicated disease. And so with that, I think we can flip over to the break. We'll do questions right after that, but I'll for sure take that, yeah, for sure.